Yep. Thank you everyone for joining the session today. So we have here Associate Professor Pecoraro, who's a senior obstetrician and gynecologist with over 20 years of experience in this specialty. He has chaired the Continuing Professional Development Committee, Subspecialist Committee, the College Publications Committee, and co-chaired the Women's Health Committee. He's also a senior clinical lecturer in obstetrics and gynecology in University of Queensland since 2000. He was also a visiting lecturer and assistant professor in obstetrics and gynecology at Bond University for 15 years and senior visiting obstetrician at Mater Mothers for 18 years and at Royal Brisbane and Women's Hospital for 14 years. So he's actively involved in the training of junior specialists, doctors, and medical students, and he has won many awards, and it is our absolute pleasure to have him on our panel. Now over to you, Dr. Pecoraro.
Thank you very much, Sophia. If I can just tell you a little bit about myself, I'm Gino Pecoraro, pleased to meet you. As Sophia said, I'm an adjunct associate professor at the University of Queensland, and I was awarded the OAM last year for services to gynecology and medical media. I'm a generalist obstetrician and gynecologist. I've been working in the area for 30 years. I stopped my regular public appointments 2 years ago and am now working mostly in the private sector, but I maintain public appointments doing locums in regional Australia in both obstetrics and gynaecology. So I feel I have an adequate insight into how both the public and the private sectors work in my particular specialty. My areas of interest are in high-risk obstetrics, particularly autoimmune disease and thrombophilia, and how they affect pregnancy, and in gynecology, in endometriosis, menopause, vaginal and minimally invasive laparoscopic surgery. A little bit more about me. I'm, happily married, father of 4, so I've lived the life of having children. I have quite a history of being politically active. I think you should know that. I'm a past state AMA president, a past federal council AMA member for 20 years. I've been the past federal chairman of the board of the AMA. I'm currently the president of the National Association of Specialist Obstetricians and Gynaecologists, and I'm the chairman of the Australian Health Practitioners Advisory Solutions Group. I maintain a health interest in medical politics and also in medical media. I write columns for newspapers and women's magazines. I have a regular radio slot on 4BC, but have also had regular slots on national news programs like the Today Show, Channel 10 News in Queensland, and various other affiliations. I'm actively working in the area of obstetrics and gynaecology. I think that's me in a nutshell. If you've got any specific questions, I'm more than happy to answer them. Sophia, over to you.
Yep. So does anyone have any questions that you want to ask Dr. Pecoraro? And if not, Dr. Pecoraro, could you please maybe share like any highlight cases that you've had over your career that may be of use to the medical legal service? Yep.
I certainly have provided medical opinions on both obstetrics and gynecological cases. I work for a number of groups, and what happens is that they send me a brief. I read the brief, I interview the patient, sometimes actually examine the patient, and then give my interpretation of where we're at on strengths and, importantly, weaknesses in any treatments that they may have received. I forgot to mention, I also sit on the Queensland boards of Avant, one of the major insurers, where I give opinions on obstetrics and gynecology matters. So I keep current on what's happening in the medico-legal space in my specialty.
And may I just ask, like, do you accept telehealth for the medical legal cases, or does it have to be like a face-to-face?
It depends. Some cases are amenable to having a telehealth consultation, but for some cases you do need to actually examine them. It has to be done on a case-by-case basis.
Yep, thank you. So does anyone have any questions for Dr. Pecoraro? You can
Oh,
just
hi.
unmute yourself.
Sorry.
Yeah.
Yep. I think I have a question. Good afternoon, Dr.
Good afternoon.
Pecoraro. My name's Pia. I act on behalf of clients. They're veterans of the Australian Defence Force with their DVA claims. And under the DVA, I'm not sure if you're aware, have their own tables for the assessment of permanent impairment. And broadly speaking, it seems a little easier for men to achieve compensation, under 10, 15, 20 impairment points. And the test for women seems to be to result in less impairment points being awarded to them. I guess my question is specifically under the tables, and I know it's a little bit difficult to ask, but where the test for sexual function for females is meeting a 10% impairment, the criteria is a persistent inability to participate in intercourse on set of a certain age. In this particular instance, it's between the ages of 40 and 64. With that criteria, the persistent inability means a woman's unable to participate in vaginal intercourse on most occasions because of physical obstruction, or at the entrance, or because of and apologise, I'm probably going to mess up the pronunciation of these, but vaginismus, or because of dyspareunia. Yes. So if you wouldn't mind, like what might cause what might a physical obstruction be? What I want to do is be able to sort of talk to my female clients about whether or not they're able to satisfy this criteria. The table's not specific, but in your experience, could you provide any examples of this persistent inability?
There are a couple of things to say, and that first of all is that I don't give an opinion without pardon me, talking around it as well. And so rather than just meeting the very, very specific criteria that Defence Forces has for obstruction to obtaining vaginal intercourse, we also talk about libido, enjoyment, anorgasmia, and initiation of sexual function, those sorts of things. And you need to be grown up and mature about this, and there are a whole heap more of other sexual activities apart from penovaginal intercourse. So we also talk about digital, oral, and anal stimulation that needs to be discussed. And so we certainly ask patients, if we're assessing sexual function, about those things. When they're talking about obstruction, they're usually talking about scarring that has occurred following vaginal tearing that can be associated with a vaginal delivery, be that associated with a tear or an episiotomy that hasn't healed properly. And that can actually make it difficult for the penis to be introduced inside the vagina. It can also affect the use of toys. Coupled hand in hand with that is vaginismus, which is a spasm of the vaginal wall so that it just clamps down and you can't get anything inside the vagina. It's a little bit more complicated than just vaginismus, because we know that we've got these muscles on the side called the pubococcygeal muscle, and that can become overactive and thickened, and that can go into spasm and cause pain. And also deeper inside pelvic muscles like the obturator internus can become quite hypertrophied or thicker and go into spasm. And both the pubococcygeal and the obturator internus muscle spasm is a protective mechanism that the body has to try to stop itself from being hurt. So cases of sexual dysfunction are always really quite nuanced and complicated, and I think it is an oversimplification of the schedule that they have. And that's why I think, sure, you have to pin your assessment on those areas, but I think that you need to have discussion around that, because hopefully that's where I think that the lawyers come in to argue those other things that may not necessarily be covered by that, if at all possible. Did that answer your question?
Oh, yes, thank you. And so I guess broadly, if a client has, one of my female clients has a liability accepted for a sexual dysfunction, normally the department might agree with the briefing a GP, asking a GP for the impairment assessment. Would it be your recommendation that that should be a specialist assessment rather than a GP one?
I'm afraid I do think it should be a specialist, at the very least a gynaecologist, but there are actual sexual therapists and sexual health physicians who are even more specialised in this area, or there are people with a special interest in sexual dysfunction who may be better, I think, equipped to undertake the detailed history and examination than is needed. If I can, by way of explanation, saying that, obstetrics and gynaecology is a broad specialty, and someone who may be only interested in preeclampsia in pregnancy may not be the best person to get an opinion from when it comes to sexual dysfunction. There are pelvic pain people, there are pelvic pain societies that have lists of people who specifically work in this area and are interested. I do a lot of endometriosis, so I see a lot of pelvic pain, and hand in hand with that is sexual dysfunction. And I certainly refer people to pelvic floor physiotherapists and pelvic pain physicians and other gynecologists who have interest in this area. So I don't think that just because you've got doctor in front of your name, you're the repository of all knowledge in highly specialised areas like this. And I think if you're going to do the best by your client, my patient, I do think it behoves you to make sure that you're getting opinions from the right people.
Perfect. Yes, perfect. Thank you.
Yep. Thank you, Dr. Pecoraro. Does anyone else have any other questions? If not, we'll probably wrap it up now. I'll publish this recording on our YouTube channel, but thank you so much, Dr. Pecoraro, for doing this session today. It was very helpful, and I hope he answered all of your questions, Pia. So yeah, thank you.
My pleasure.
Everyone.
Thank you very much for listening. Bye-bye.
Thank you. Bye. Just gonna stop recording now.